Okay, so I think that's about a good time to get started. So welcome everyone to the latest ACP webinar, which this month is on brain metastases. I'm pleased to have two, I think, really excellent speakers for the webinar this evening. I'll introduce them in a second. So without any further introduction, I'd like to introduce our first speaker, who's Dr. Vinton Cheng. So Vinton is recently qualified, recently finished his training in Leeds, and is now an associate clinical professor at the University of Birmingham, working with Colin Watts on a variety of projects. And he's also an honorary consultant medical oncologist at Birmingham as well. He's here to talk on systemic treatment of brain metastases with a focus on breast cancer. And I'm sure he is one of the best people to talk on this. So without any further ado, I'll hand over to Vinton for his presentation.
So thank you very much for the kind introduction and for inviting me to give a talk today, and good evening to everyone attending. So as Richard mentioned, I'm going to be talking about the systemic therapies for brain metastases, specifically focusing on breast cancer. And in this talk, I'm going to briefly give an overview of brain metastases, why it's important for our patient population, and where we're at the moment in terms of the management, and also importantly how the landscape of brain metastasis management is changing, and then to focus in on the systemic therapy options for breast cancer brain metastasis in particular. So when we think about intracranial central nervous system metastases, there are two main types that we talk about: the parenchymal brain metastases, and as you can see here over on the left, I'm just going to change my pointer. In this kind of T1 weighted gadolinium enhanced MRI scan, what these white arrows highlight are multiple brain metastases, and these are the parenchymal brain metastases. And over on the right side, we also have the leptomeningeal disease, which, as the white arrows highlight, are kind of these fine linear lines affecting the leptomeninges. This talk, we're going to focus specifically on the parenchymal brain metastases and its management with systemic therapies. Brain metastases can, of course, occur due to spread of cancer from multiple different sites. And there are a few which seem to have a particular tendency to spread to the brain. The top one is lung cancer, which accounts for about 50% of all brain metastases cases. Breast cancer is next, accounting for about 20 to 30%, and then melanoma for about 10 to 15%, followed by colorectal cancer and then renal cancer. But many other cancers have the possibility of spreading to the brain as well. And in terms of the incidence, within the UK, it's estimated that there are around 16,000 new cases per year. Now, of course, this is very difficult to estimate, given that we don't always count every single case. And there are autopsy studies which show that there are probably a higher number of cases that are undetected through asymptomatic cases. We also know that brain metastasis is an increase in clinical burden, due to an overall increase in the aging population and therefore subsequently the incidence of cancer. We also know that due to improved control of extracranial disease, that means patients are surviving for longer and therefore have a greater risk of developing brain metastasis. However, although brain metastasis is typically seen as a late presenting symptom, actually we are seeing more patients presenting earlier with brain metastasis as well. And also due to more liberal use of neuroimaging, including screening for clinical trials. So why are brain metastases important? Well, we know that it is a major cause of morbidity and morbidity for our patients. Not just from the physical sense, with the raised intracranial pressure causing symptoms such as headache, altered consciousness, seizures, but also loss of function through limb weakness, visual and speech disturbance. But also, it can impact the patient psychologically. It can cause personality changes, memory loss, cognitive deficits, and also mood changes. And socially, it impacts on the patient in terms of loss of independence, social withdrawal, and also, importantly for our patients, their inability to drive. In terms of our current treatment paradigms, apologies, the kind of local therapies remain the mainstay of initial management for brain metastases. We typically use surgery for limited and accessible brain metastases without any or any significant extracranial progressive disease, and in particular if it has mass effect. And then stereotactic radiotherapy we typically focus on for less accessible but more limited metastases, and I know there's a talk next about SRS. However, whole brain radiotherapy is typically used where there's more extensive multifocal disease, and it remains a suitable option for a select group of patients. However, generally we try and avoid whole brain radiotherapy due to the risk of long-term cognitive deficits. And then systemic therapies remain an important tool. However, there was always been a historical concern around the penetrability of systemic therapies across the blood-brain barrier. And we know that brain metastasis remains a major unmet need. As we talked, as previously discussed, it has a disproportionate impact on the patient and also on the family and carers. Part of the concern is that they have typically presented late, meaning that they are usually symptomatic and may have worse outcomes. They have also been historically excluded from systemic therapy trials due to the main concerns being historically poor outcomes and the concern around the effect masking the benefits of treatment, and then also the risk of neurological symptoms and also the concern around brain penetration. And this has resulted in more limited treatment options in the systemic therapies. And then finally, there's also the concern around clinical nihilism, so perceptions around brain metastasis and whether there is any point in treating them. However, there has been a very clear shift in the culture towards brain metastasis management. And as you can see here, there have been a number of large studies in melanoma and also in lung cancer, which have clearly demonstrated that treatment can be delivered to patients with brain metastases and they can be actively recruited with demonstration of benefits as well. For example, with the immunotherapies and in particular with the small molecule inhibitors that have come through. And also over on the right-hand side, as you can see here, there's a growing interest in undertaking clinical research into brain metastasis over the past decade. In patients with breast cancer with brain metastasis, what we can see here is that over time, there has been a gradual improvement in overall survival. So from 2012, when we split these patients prognostically, survival was measured in a short number of months. However, that has almost doubled. Over the past decade. And with the best prognosis group, we can see that they have a median survival of around 2 years, and more recently, it looks about approximately 3 years. And so there's been a definite shift in terms of the way that we manage these patients and therefore the outcomes. And that has largely been down to the improvements in radiotherapy. However, systemic therapies have also contributed, and in particular, the changes with HER2 positive disease. And when we think about breast cancer brain metastasis in particular, we also know that it is disproportionately affected by particular molecular subtypes. So, for example, with HER2 positive disease, approximately 30% of patients are expected to develop brain metastases at some stage in their journey. And in triple negative disease, there is also a relatively high burden of 20 to 30%. However, we mustn't forget that hormone receptor positive breast cancers can also develop brain metastasis. So now I'm going to talk about the systemic therapies and some of the clinical trials that have been used to test these in breast cancer in particular. So thinking about the hormone receptor positive breast cancer, first of all, one study that's recent that has been published is in the use of abemaciclib, which is a CDK4/6 inhibitor, typically used in the in the first-line setting with an aromatase inhibitor. And in this study, which was a phase 2 study, which was uncontrolled and non-randomized, they tested abemaciclib with or without an aromatase inhibitor in patients who had been heavily pretreated with hormone receptor positive disease. Interestingly, they also included patients with HER2 positive disease, as you can see here in these 4 separate cohorts. One of them, cohort B, they included patients with HER2 positive disease, and also patients with leptomeningeal metastases and those who had surgical resection as well. And what they showed was that in the patients who had a surgical resection, they were able to detect the abemaciclib in the resected tissue, indicating that there was penetration across the blood-brain barrier. And importantly, there was some demonstration of benefit with overall response rates intracranially in cohort A. So these are the patients with a hormone receptor positive and HER2 negative disease of around 5%, so bearing in mind that these patients were heavily pretreated. In the other cohorts, unfortunately, there wasn't a significant, a response seen. However, there was an intracranial clinical benefit rate, which was defined as disease control of greater than or equal to 6 months. So that could be stable disease, response, a partial or complete response of around 25% in cohort A and 10% in cohorts B and C, respectively. In the triple negative breast cancer space, there hasn't been a huge number of studies. However, with sacituzumab govitecan in the phase 3 ASCENT study, this did examine in a post hoc analysis patients who had stable brain metastases on recruitment to the trial. So sacituzumab govitecan is an antibody drug conjugate, which is being increasingly used in brain metastasis, in breast cancer management. And this one is directed against a TROP2, which is coupled to SN38, which is an active metabolite of irinotecan. And what has been shown is that it can be directed towards the tumor, and then it releases the SN38 against the tumor, but also in the microenvironment as well, creating a bystander effect. So in the phase 3 ASCENT study, they undertook an exploratory analysis for patients who had a metastatic triple negative breast cancer that was refractory to relapsing after at least 2 prior chemotherapies. And they found, and in this exploratory analysis, there were 61 out of 500 patients, so around 10%, who were enrolled and had stable brain metastasis, and they only included patients who had prior treated brain metastasis on enrollment. And around half of these received the sacituzumab govitecan, and the other half received treatment of physician's choice. And what they showed was that there was a modest improvement in the progression-free survival with approximately 3 months in the patients treated with sacituzumab govitecan versus around 1.5 months in the control group. And an overall survival wasn't significantly different, however. The importance of this study was that the overall population was small in the brain metastasis population, and it's important to recognise that they had a poor prognosis overall. In the HER2 positive space, however, there has been more excitement in terms of systemic therapies directed against brain metastasis, and one of the larger studies that we have available is through for example, the Camilla trial, which was examining trastuzumab emtansine, and they also performed a exploratory analysis in breast cancer patients who had brain metastases. And interestingly, they included patients who had asymptomatic disease but had no prior treatment. So out of the nearly 400 patients who were recruited with a baseline brain metastases. Just around a third of them had evaluable disease, and nearly half of those had no prior treatment. And they did also separate out patients who had previous radiotherapy to the brain. And what they found was that, as you can see in this waterfall plots here, actually there was quite a significant proportion of patients who appeared to have a response in the brain in the target lesions, and an overall response rate, so in those who had a partial or complete response, was around a fifth of all of the patients. And in this plot here, you can also see, in terms of the changes in the tumour growth, there was a proportion where there was an apparent response in the brain, and those who had no prior radiotherapy as well. And importantly, the safety was generally similar in patients who didn't have any baseline brain metastases. And therefore, this was important in demonstrating that there were effective drugs, in particular with this newer class with the antibody drug conjugates. And then more recently, we now have the trastuzumab deruxtecan, again directed against a HER2 positive metastatic breast cancer. And so kind of the first study that focused on was the Destiny Breast 01 study, where they also performed a subgroup analysis. And in this trial, they specifically included patients who'd had prior treatments to their brain metastases. So again, stable and controlled brain metastasis. But what they showed was that the survival was similar, whether or not the patients had a brain metastasis when treated with the trastuzumab deruxtecan. And as a result, we've now been able to use trastuzumab deruxtecan following trastuzumab emtansine in patients with stable or treated brain metastasis from the Cancer Drugs Fund. And more recently with Destiny Breast 03, which directly compared against trastuzumab emtansine, we can now also use trastuzumab deruxtecan in an earlier setting. More specifically to the brain metastasis population, particularly in those who were untreated, we have the Tuxedo 1 trial. So this was performed in Austria, and they specifically tested in a single-arm phase 2 trial the effectiveness of trastuzumab deruxtecan in patients with the HER2 positive breast cancer and newly diagnosed untreated brain metastases, or who have progressive brain metastasis after previous local therapy. And so this was a relatively small study which recruited 15 patients. And as again, what you see in this waterfall plot is that the majority of patients did appear to show a response to the treatment, or at least had stable disease compared to baseline. And surprisingly, around 13% had a complete intracranial response. 9 of the patients had a partial intracranial response, and 3 had stable disease. So this was really exciting in opening the possibilities of controlling brain metastasis, particularly in the HER2 population, who are particularly susceptible to this condition. Separately from the antibody drug conjugates, we also have the small molecule inhibitors. And so with the HER2 CLIMB study, specifically which was examining tucatinib, trastuzumab, and capecitabine in HER2 positive metastatic breast cancer, which was reported about 3 years ago now, what they showed that was untreated brain metastases, including those that were larger than 2 centimeters in diameter, could be treated with this combination and showed a benefit in terms of survival. And so in this study, they recruited nearly 300 patients and randomized to either the tucatinib combination or to placebo in combination with capecitabine and trastuzumab. And accounting for in the multivariate analysis, there wasn't a benefit towards improvement in progression-free survival and also overall survival in patients treated with tucatinib. And in the patients in particular with the measurable disease, the combination had a response of nearly half compared to just 20% in the control arm. And there was also an improvement of nearly double the progression-free survival with the placebo group having a 4.1 month median progression-free survival compared to the tucatinib group with 9.5 months progression-free survival, and similarly with the overall survival from 11.6 months to just over 20 months. And so that's really given us a lot more options for treating patients with HER2-positive breast cancer and brain metastases. And looking into the future, what could be coming through in the horizon? Well, what has also been recently reported is the options of using novel technologies, in particular focused ultrasound. And so focused ultrasound is the use of directed sound waves, which can be targeted with millimeter precision transcranially, and specifically to open the blood-brain barrier when used with microbubbles delivered intravenously, with the aim to then allow drugs to be able to penetrate the blood-brain barrier, which is, as we previously discussed, is one of the major barriers to systemic therapies getting through to the tumours. And what you can see here on these images is that in A is prior to blood-brain barrier opening, and then subsequently when the focused ultrasound is directed against the tumour, and then later on you can see that there are changes in the composition of the tumour on the T1 weighted gadolinium contrast enhanced MRI, and then subsequently the blood-brain barrier reseals itself, usually within about 24 hours. And when they used, when this group in Canada used a radio-labeled trastuzumab, they also showed that there was an enhancement after blood-brain barrier on PET imaging, indicating increased leakage of the increased extravasation of the trastuzumab into the brain tumor. And again, the possibility to direct in this focused ultrasound is particularly important. And subsequently, they also showed some responses, although this was a small early phase study, and therefore ongoing trials are in place to study the effectiveness of this method. So just to summarize, what we know is that brain metastasis is clearly a serious complication of cancer, and it is growing in incidence. Traditionally, it's been poorly studied, and consequently, poor outcomes have been in place. However, the landscape is changing. I think there is definitely a lot more optimism within the oncology team that outcomes will improve in the near future. What we're seeing is that there has been a real progress through an increase in the number of clinical trials that include brain metastasis patients, and also particularly for the breast cancer population, trials that are specifically including patients with breast cancer brain metastasis. There are more novel therapeutic systemic agents available now, particularly with the immune therapies, small molecule inhibitors, and in particular with antibody drug conjugates, which seem to have particular pharmacokinetic properties which are conducive to targeting brain metastases. And these have also demonstrated proven benefit in breast cancer brain metastasis, particularly in HER2-positive disease. And so I think there needs to be ongoing investigation, particularly for example, with triple-negative breast cancer and also with a hormone receptor-positive disease. Of course, there are still ongoing challenges. We need to better define these intracranial endpoints and be prepared to use them consistently across the literature. We're still trying to overcome the clinical nihilism towards brain metastasis and improve the recruitment of brain metastasis patients, and hopefully design trials in which these patients will be eligible. Then also needs to be a more consistent definition of how we define active against stable and asymptomatic brain metastasis, and also not forget that patients unfortunately do present late, often symptomatic, and therefore still need options available for them. And also in terms of the choice of the investigative therapeutic agent, ensuring that we're using ones where there's expected to be good penetration of the blood-brain barrier. So I'm just going to end it here, kind of just thinking about how we can think about the paradigm for brain metastasis care, and separating kind of extracranial disease against intracranial relapse disease, and therefore the importance of more local therapy clinical trials and also early detection as well. But then the importance of when there's both extracranial and intracranial relapse, how we need more options in terms of systemic therapy clinical trials. Okay, thank you very much.
So just before, whilst anyone's typing any questions, so you've obviously talked about the stable versus unstable sort of brain metastasis paradigm. At the moment, in terms of breast cancer particularly, what treatment options are proven for people that have sort of active brain metastases?
Yeah, so in terms of these newer agents, we're probably focusing on the HER2 positive disease. There's the trastuzumab deruxtecan and the tucatinib, as mentioned. Currently on the in terms of the guidance that we have for untreated brain metastasis, it's tucatinib with trastuzumab and capecitabine, whereas for patients with brain metastasis but who have received treatments and where it's controlled, it's still trastuzumab deruxtecan. That may well change as we get more experience with the trastuzumab deruxtecan as more trial data come out.
Okay, and I guess the second question is in terms of the other treatments that we have at the moment, so chemotherapy and immunotherapy, is there any evidence for their effectiveness in brain metastases, particularly in the triple negatives with immunotherapy at the moment?
That's a good question, actually. So immunotherapies haven't typically included patients with brain metastasis, mainly around the concerns of the steroid use and also the risk of pseudo-progression as well. As I mentioned, in melanoma, there has been good evidence of using immunotherapies and its benefits in, say, asymptomatic brain metastasis. Part of the issue is kind of, again, defining that population and picking them up early enough to be tested. But so far, we don't have the similar evidence in breast cancer. But the hope is that there will be trials that will investigate that in the future. In terms of the use of chemotherapies, I don't think we would generally rule them out, because whilst there is some question around the penetration across the blood-brain barrier, what we know is that the blood-brain barrier is altered around the tumours, what we call the blood-tumour barrier. So there probably is some leakage there. I mean, obviously we can see extravasation of the gadolinium, so there must be some leakage there. And so we wouldn't rule them out, but however, the expectation of the effectiveness based on kind of experience hasn't been great.
Perfect. And we've got a question here from the audience from Claire Fuller. So obviously you've focused on breast cancer in this talk, but do you know, are there trials that include other tumour types such as colorectal cancer that are in the pipeline?
Unfortunately, I don't know specifically for colorectal cancer. I mean, we are undertaking at the moment a kind of a review of a mapping review of all the clinical trials that have been published and that have included brain metastasis patients, and I'm sure there will be those that have included colorectal cancer patients. But you know, I'm not aware of specifically one that for a particular treatment. But yeah, happy to follow that up.
And I think from that review, we've found that obviously the majority of the trials were looked at breast and lung cancer and melanoma, because they're the ones that numerically have more metastases, aren't they?
Yeah.
So we've got another question from Alison Berner. So how do you think we overcome the challenge of designing trials for treatment of symptomatic brain mets? could there be a role for advanced enrolment and consent for those at a high risk to go on to get brain mets where capacity might be affected?
Yeah, and those are really great questions. And I think part of that is down to the culture and whether we've got the right framework, and in particular the regulatory framework, to promote the inclusion of brain metastasis patients into these trials, recognizing that it is a growing population going to be facing this more and more in the future. So we need these answers, and patients are clearly asking for it as well. One thing that's happened in the US is that there has been stipulation from the FDA about to consider these populations. I think what we do need to think more about is the intracranial endpoints, and perhaps examining this separately from the extracranial disease, and therefore still kind of getting data for both, so that you can almost separate out. Because I think that's always been the concern. I mean, if the patient dies from the brain metastasis, then that could unfortunately skew the results, and therefore pharmaceutical companies haven't been particularly keen to include that historically. But I think the landscape is changing, both in terms of how we analyze these studies, so the greater use of intracranial endpoints, but also with these new trials where pharmaceutical companies are becoming more brave in using it. But I think also in terms of our community, the willingness to challenge that and to say, well, actually, no, I think we should include brain metastasis, and might be starting with an asymptomatic population, but once there's demonstration of benefits, then opening that wider to a symptomatic group. So there probably is multiple different factors that can play into that regulatory, cultural, and then also conversation with the pharmaceutical companies. Advanced enrolment and consent for those at high risk to get into brain mets when capacity might be affected. I think that's always going to be a challenge, where a patient doesn't have capacity or loses capacity, and then what happens? Should they stay on the trial, or do they need to then be removed and therefore censored? I don't think I have an answer for that. That's more of an ethical question at this point in time, and probably will need extensive kind of stakeholder engagement, particularly with patients, about how willing they would be to accept that type of model where we continue. I suppose if they lose capacity, then we probably would want to stop anyway, because the brain metastasis is progressing. They're clearly not benefiting from the treatment. So probably my thing is probably we wouldn't be doing advanced consent.
Perfect, thanks for that. And I don't think there's any other questions from the audience. I had just one quick question about the focused ultrasound. Is who does that, and how straightforward is it as a procedure? Is it something that would be?
Yeah, so it's still very much in the experimental phase at the moment. It's a kind of technology that's being more widely used in the US, North America. And as I said, that study was undertaken in Canada. We do actually have a machine down in Imperial, and that's being used for a non-oncological purpose, for thermal ablation in essential tremor. I think in the UK, this is a technology that's going to grow, and hopefully in the future we'll see more of that. But yeah, nothing I think that's really in the immediate horizon for our patients. But I'd hope in the coming few years, and particularly with the trials coming through from the US and growing acceptance of this technology and the safety in our patients, that we'll be able to think about this more and push for it, really.
Brilliant. Thanks, Vinton. I don't think there's any other questions in the chat, so I think perhaps we can move on to our second talk. But obviously, if anyone has any other questions for Vinton, we can ask those at the end of the evening. So I'd like to move on to our next talk, which is from Dr. Jennifer King, who's a consultant clinical oncologist at the Christie. She specialises in lung cancer, brain metastases, and pituitary tumours. She completed her training in the Northwest, and the key aspect of her work is integrating lung cancer and brain metastasis management pathways. I think a really excellent person to come and talk to us. She's also, I'm aware that the majority of the audience here will be medical oncologists, and so I think it's really good for us to actually get an understanding of what we're referring to when we talk about SRS and WBRT and FSRT and all of the other acronyms that I'm sure we pretend to understand but don't really. So I'd like to hand over to Dr. King to talk about the role of radiotherapy in brain metastases. So over to you, Dr. King.
Thank you, Richard. Thanks for the introduction. So hello, everyone. Let me just share my screen with you. So I'm going to talk to you today over the next 20 minutes or so about radiotherapy for brain metastases. And I am aware that I'm speaking in a medical oncology setting, so I won't go into lots of intricate details about radiotherapy, but what I have tried to do is summarize the evidence of why we give what we give and why we do what we do, particularly focusing on SRS, but I'll also talk about whole brain radiotherapy. We'll touch on a little bit about who should go for surgery versus SRS, and also what we consider at the Neuro-Oncology MDT and what information is important for us to know to actually be able to come up with a decision about treatment for patients. I've touched on the end a little bit about systemic treatments for brain metastases, more in terms of the timings in relation to radiotherapy. And as Vinton has eloquently shown, there's quite little evidence really, and thankfully we are getting more for this, but we can talk through some of that at the end. So, as you've heard, brain metastases are common. They can occur in up to 40% of all cancer patients, and the most common tumour types to spread to the brain are lung, followed by breast and melanoma, and colorectal and renal are also becoming more common to spread to the brain. And the incidence is rising, and that's due to a combination, as Vinton said, of patients living longer, mainly due to increases in systemic treatments available for patients. And a lot of the prognostic tools that have been developed over the years looking at patients with brain metastases consistently show that a patient's performance status and the extent of their extracranial disease, whether it's controllable or not, really drive the prognosis for patients with brain metastases. So as we're seeing patients who are having their systemic disease treated by kind of increased targeted agents, etc., we're seeing patients living longer with brain metastases. And in that kind of realm, we've really seen a shift from kind of palliation to survivorship. So if you look back just to the 1990s, when our prognostic scoring group was around the kind of recursive partitioning analysis, the patients in the best prognostic group had a survival of around 7 months. Whereas now we've moved on more, there are lots of prognostic tools, but if you look at the graded prognostic assessment tool that looks at the individual tumour types and also takes, particularly for lung cancer, into account some of the molecular drivers, you're seeing patients that have a median survival in the best prognostic groups of around 4 years. So this is a massive difference. And we're becoming more aggressive with our management of brain metastases. We're treating more patients with SRS. And a lot of this, as I've mentioned before, is to do with the explosion of systemic treatments available for these patients. And we're seeing a significant reduction in the use of whole brain radiotherapy as well. I'm not going to dwell too much on the symptoms of brain metastases. You've all seen patients who present with them, but essentially the symptoms that occur occur due to where the brain metastase is and whether it's causing any pressure on the brain or not. So you can get a whole range of symptoms. However, about a third of patients actually are asymptomatic from their brain metastases, and they're actually picked up incidentally or on routine screening. And it's important not to forget the impact that a diagnosis of brain metastases can have on a patient. So it's not just, as we talked about, the symptoms, they lose their driving license automatically. And this is a common source of frustration that we see with patients coming to our clinic who've had a routine brain scan, perhaps for a trial, that's shown a tiny metastase that's not causing any symptoms, but they've had to have a massive lifestyle change because they can't drive anymore. And it's important that they're informed, that they need to inform the DVLA. They're not allowed to drive for a minimum of a year, depending on how many brain metastases and where they are. And in the past, most patients wouldn't survive to be able to reapply for a driving license, but actually with patients living longer and disease being more controlled, we are seeing patients that come through that year or 2 year point and are at a position where they can reapply for a driving license. So it's important they're informed of the DVLA guidance. So moving on to radiotherapy techniques. So perhaps the most long-standing radiotherapy technique for brain metastases is whole brain radiotherapy. So this is a really simple technique. It's delivered by 2 beams that come from either side of the head, and it treats the whole brain to a uniform dose, and it's usually delivered in 5 or 10 daily fractions across 1 or 2 weeks. And there's no clear evidence to say that 10 fractions is better than 5. The outcomes were similar for both. It's very simple, as I've said. It doesn't take long to plan. Can be used on any standard radiotherapy LINAC machine. It doesn't need specialized commissioning like SRS, and it's generally delivered by the disease specific clinical oncologist rather than a neuro-oncology, although that might vary, I guess, between centers. As I say, it was something that used to be kind of standard of care for brain metastases patients, but it's really fallen out of favour, as we'll come on to. And one of the main drivers of that are the significant side effects that it can cause, particularly neurocognitive side effects for patients. And so when we look at who benefits, there's no good high-level evidence really, apart from perhaps in lung cancer. If we look at historical series, so kind of retrospective studies really, you found that patients who had whole brain radiotherapy perhaps had a couple of months survival benefit compared to those who did not receive it. However, in 2015, the Quartz trial was published, and this was a phase 3 trial that looked at patients with non-small cell lung cancer who had inoperable brain metastases. And they randomized between whole brain radiotherapy and best supportive care versus best supportive care alone. And what they found was that there was no survival benefit in giving whole brain radiotherapy. And there was no difference in quality of life or steroid use. And so after this trial, whole brain radiotherapy really kind of fell out of favour, and we don't use much of it. It's important to note, however, with this trial that only a small percentage of these patients were in the best prognostic group. The majority of patients were of poor performance status and had no kind of systemic options available to them with progressing extracranial disease. So they had kind of poor prognosis anyway. So in that group of patients, whole brain radiotherapy perhaps doesn't give any benefit as opposed to supportive care alone. However, in the patients who are in the best prognostic group, so those who are young, who have good performance status, and who have further systemic treatment lines or controlled extracranial disease, may benefit. There's only a small number of patients in this trial, but there was a kind of trend towards benefit for them. And so it could be considered for those patients, particularly if the systemic treatments available to them don't have a very high CNS kind of penetrance. And one of the techniques that's kind of been developed more recently to try and avoid the neurocognitive side effects that are associated with whole brain radiotherapy is hippocampal avoidance. And you may have heard of that. So the hippocampi are a paired structure in the brain that you can see kind of outlined on these images. And essentially, this part of the brain is thought to be involved in new memory formation, and it's felt to be the area that, if irradiated, helps drive some of those neurocognitive side effects. And so trials have been conducted where the hippocampi are avoided with radiotherapy. So this is a much more complex planning technique as opposed to your standard whole brain radiotherapy. It takes longer to plan, but you essentially avoid those areas. And what it found was that there was no survival difference between the two groups, so those having hippocampal avoidance versus those who did not. However, the patients who did have hippocampal avoidant whole brain radiotherapy had better outcomes in terms of fatigue and neurocognitive functioning. And so this is recommended in a lot of the guidelines, and I know particularly in other countries it has been taken up. We don't tend to use much of it in the UK, and I think part of that is we don't use much whole brain radiotherapy really. But there may be a place for it for patients who perhaps are going to have more kind of prolonged survivals, perhaps as we're hearing about the HER2 positive patients. If they're not eligible for SRS or surgery, there might be a place there for those patients. And there are trials looking at patients who have multiple brain metastases, so kind of over 15 brain metastases. We know that these patients are likely to develop more and more, and so whole brain radiotherapy may have a benefit over SRS for these patients. And so there are trials, I think, ongoing at the moment looking at patients with over 15 brain mets having hippocampal avoidant whole brain radiotherapy versus SRS, and hopefully we'll have more concrete evidence for these patients following those trials. So moving on to SRS, so stereotactic radiosurgery is highly targeted radiotherapy. It spares the whole brain and it's much better tolerated than whole brain radiotherapy. It's where we give a high dose of radiation, usually in a single dose. If you have a particularly large brain metastase or a brain metastase that is close to an eloquent location like the brainstem or organs at risk like the optic nerves, then sometimes we do fractionate, and that's where the SRT, the stereotactic radiotherapy, comes from. That just means that we fractionated, but it's still a high dose and a small number of treatments. It's not appropriate for patients who have diffuse disease like leptomeningeal disease or skull bone metastases, and it's only available at a limited number of centres that have specialised commissioning. And you might have heard of different platforms. There are different machines that can deliver SRS. So you may have heard of Gamma Knife, that's perhaps the most well heard of, but CyberKnife, there's Linac based. And essentially these are just different machines that deliver it. And there are different technicalities in how the patient is immobilized, but the dose, the side effects, the outcome of SRS is the same regardless of which machine is used to deliver it. So who benefits from SRS? So initially SRS was actually first introduced as a boost to whole brain radiotherapy. So we've got these two trials conducted kind of late 90s, early 2000, when whole brain radiotherapy was standard of care. So these looked at SRS in addition to whole brain radiotherapy versus whole brain radiotherapy alone. And they were looking at patients with limited number of metastases and good performance status. And what they found was that adding SRS to whole brain radiotherapy, patients had a better performance status at 6 months. They had reduced steroid requirement in all patients that were treated. However, there was only a survival benefit shown in patients who had either a solitary metastase or those that were in the best prognostic group at the time, which was the RPA group. So those patients that are young, good performance status with no extracranial disease. And then subsequent kind of studies have looked at these patients with newer prognostic assessments like the GPA that I mentioned before. And they also found that it was those patients in the best prognostic groups who had a survival benefit. Patients in the poorer prognostic groups did not. And then, as I mentioned, those trials were looking at SRS alongside whole brain radiotherapy, but we don't like whole brain radiotherapy because of the neurocognitive side effects. And so these trials were conducted looking at, can we give SRS alone? Can we omit the whole brain radiotherapy? I'm not going to go into each of them in detail, but just to summarize what they showed, that for those patients who there was no survival difference between the two groups. So adding whole brain radiotherapy to SRS does not improve survival. What they did find was that if you had whole brain radiotherapy in addition, you had worse neurocognitive side effects following treatment. However, those patients who didn't receive whole brain radiotherapy, so those that had SRS alone, actually had a higher risk of brain metastases cropping up elsewhere in the brain. And so following these, we don't give whole brain radiotherapy alongside SRS, we give SRS alone. However, we are mindful of the fact that patients are at higher risk of brain metastases cropping up elsewhere. And that's why if patients remain fit for treatment, we suggest that they have MR scans with contrast every 3 months after treatment to look for brain metastases occurring elsewhere in the brain so that they're picked up earlier and can be treated if appropriate. So then those trials that we looked at a limited number of brain metastases. And so then the question was asked, well, actually, can we treat patients with more than 3 brain metastases? You know, it's a very arbitrary number. And again, there's very limited evidence, limited high-level evidence. There is this prospective observational study that was performed in a number of centres in Japan, had over 1,000 patients. And this looked at patients with up to 10 brain metastases who were of good performance status. And it's really important to state here that the total volume of those 10 brain metastases had to be less than or equal to 15 mil. So we're talking here about 10 small brain metastases, not large ones. And what they found was that patients who had a solitary metastasis, the green line on the graph, had a better survival. But if you grouped the other patients into groups of those with 2 to 4 versus 5 to 10 metastases, so that's the blue and the red line on the graph, there was actually no difference in survival. And so we've kind of conferred from this that there is a benefit to patients who have more than 3 or 4 brain metastases, but providing that the total volume is small. And again, there's evidence that volume is more important than number. So the decision to use SRS must balance the likely benefits against the risk of complications and side effects, including radionecrosis. And evidence suggests that radionecrosis becomes more likely as the total brain volume increases. So the upper limit of 20 cc has been identified as a reasonable cutoff point where that kind of risk benefit tips. And so this could incorporate a tumour, a solitary tumour of approximately just over 3 centimetres in size, or multiple smaller tumours. And as you can see from the images here, actually those 3 brain metastases have a smaller volume than that one metastase on the left of the image. And so our UK guidelines are that the total volume needs to be less than 20 cc. And it's important to consider when we're thinking about treating patients with more than 4 metastases that actually the planning and the treatment time increase for these patients. And that does vary on the different platforms. So as I said, the different machines. We're currently updating our machine here at Christie, but at present, until we update, we treat our brain metastases sequentially. So that means we treat, if a patient has 4 brain metastases, they're not all treated at the same time, they're treated one after another. And each brain metastase takes 40 minutes to deliver the radiotherapy. And so as you can imagine, if you're treating 10 brain metastases, that's 400 minutes of treatment time. And so it just isn't practical to treat patients with, you know, more and more brain metastases. There are newer machines, and like I say, we are updating our machine where you can actually treat them together using arcs of radiotherapy that go round that should bring the treatment time down. But that is something to consider in terms of, you know, if patients have progressing extracranial disease, you don't want to be delaying their systemic therapy because you're treating hundreds of metastases. Then just briefly when to operate. So there are specific scenarios when surgery should be considered for its immediate therapeutic effect in patients with brain metastases. So this includes patients with large brain metastases. So as I said, we're limited by what we can treat with SRS, and generally just over 3 centimetres is our upper limit. So if a patient has a brain metastase which is larger than that, but they're otherwise fit, then we may consider surgical resection. Also, if patients have brain metastases causing raised intracranial pressure or neurological impairment, then surgery is better than SRS, because SRS will increase the edema and increase the symptoms in the short term. The posterior fossa location often is a surgical indication because of the risk of obstructive hydrocephalus. And cystic or necrotic brain metastases are another kind of relative indication, because they may respond less well to stereotactic radiotherapy than to surgery. And often a question that is asked is SRS better or worse than surgery? And there are no head-to-head trials, and actually it's a discussion as to what is better for that patient in terms of what's happening elsewhere in their disease. And it's in our neuro-oncology MDTs, we have both the neurosurgeons and the clinical oncologists, and it's working together, not one versus the other. I've mentioned where we would prefer surgery. SRS is usually more practical if there are multiple metastases, or if you have metastases that are in eloquent locations. For example, if you've got a brain metastase in a brain stem, you can't resect that, or it's very difficult to anyway. But we can give SRS depending on the size and obviously patient fitness. And it's also, when you're thinking about brain metastases, for disease sites outside of the brain, when you resect a cancer, you like to have a normal rim around the tumour of tissue to know that you've got it all out and you've got all that microscopic spread that might be around it out. But it's impractical to do that in the brain. You can't resect normal bits of brain away. And so often the margins are very small and there's a high risk of recurrence. So if you've got a brain metastase, which is kind of fairly small, asymptomatic, if you're thinking about surgery versus SRS, actually SRS, the surrounding tissue around it will get a dose of radiotherapy, and so actually maybe better served with the SRS, and that's why we generally tend to go with that rather than resecting. Just a few pictures, because I like pictures. So these are areas that we treat with SRS. So you can see the multiple metastasis scan, then you can see a small metastase within the brainstem, that again we would prefer SRS to. And then sometimes patients can have multimodality treatment, either surgery and SRS. So for example, this patient had a large metastase in the posterior fossa, as you can see in the first image, that's best served by surgery because of the risk of obstructive hydrocephalus. But they had a smaller metastase elsewhere in the brain that we then went on to treat with SRS. In general, we do surgery first, followed by SRS, if we're going to use this approach, because surgery is generally used for the brain metastase that's going to cause the problems. So how do we decide who gets SRS? So in the UK, we're bound by the commissioning criteria. And thankfully, this does actually correspond to who benefits from the treatment, as we've seen. So we're not allowed to give SRS unless it's been discussed in a neuro-oncology MDT. Patients need to have a good performance status, so Konofsky performance status over or equal to 70. So this corresponds to a WHO or ECOG performance status of 0 to 1, or perhaps a good 2. The diagnosis of cancer, they need to have an established diagnosis of cancer. And they need to have absent or controllable primary disease. So you can see that it's so important that we have the input from the primary oncology team to guide us with this. As neuro-oncologists, we can't possibly know all the different systemic treatments for all the different disease sites. And so we really need that input into the MDT to be able to make a sensible decision for these patients. commissioning criteria, absence of pressure symptoms that we've talked about, tumour volume less than 20 cc, again, as we've talked about, and they need to have a prognosis over 6 months. Patients who have a prognosis less than 6 months are unlikely to benefit from SRS, and it's not commissioned, so we can't give it. So again, that's where we need guidance really from the primary oncology teams as to what the likely prognosis is. And there are NICE guidance last updated in 2021 that again correspond nicely with the commissioning criteria and with the evidence. And you'll also notice on here that they mention systemic treatment for those tumours that are likely to respond, so germ cell or small cell, and this is generally first-line treatment for those patients. So when we're in the MDT, we don't just look at the brain imaging and make a decision from that. It's really important that we know about the patient as a whole. So we need to know about their extracranial disease. They need to have an updated CT staging scan, and we need advice from you guys or the primary team really to tell us what their prognosis is and what treatment options they've got. And it's increasingly important when we're thinking about whether we actually switch to have a systemic treatment first as well. So we're going to have increased kind of conversations as time goes on. Obviously, the intracranial disease we look at and is very important, but also patient-related factors, their performance status, and any medical problems that might exclude them from having surgery. And all of this needs to be included in neuro-oncology MDT referral, otherwise we can't come to a decision really about what's best for that patient. Toxicity, as I've said, SRS is generally better tolerated than whole brain radiotherapy. A lot of patients have very minimal toxicity. Patients may feel tired. They may experience increased edema that can present as headaches or nausea or vomiting or worsening of existing symptoms. They may need an increase in their steroids if they occur. All patients with brain metastases are at higher risk of seizure. And unlike whole brain radiotherapy, where patients will lose their hair, for SRS, it's generally only if the brain metastasis is very close to the skull. They may have a patch area of hair loss over that area. And it's unlikely to be permanent unless it's very close to the skull and they've had a high dose in that area. And there's a risk of radionecrosis that we'll talk about in a minute. Steroid management varies centre to centre. Here we give a standard steroid regime starting on the first day of treatment that I've put up there. If a patient has a very small asymptomatic metastasis, we would decrease this, particularly if they're thinking about, or we're thinking about trying to get them onto immunotherapy. We want to try and bring those steroids down quickly. Patients don't require routine prophylactic anticonvulsants. They should only be prescribed if the patient has had a seizure. And steroids, generally, if a patient drops down on a dose and they get worsening symptoms, significant symptoms, go up to the dose that last controlled it and just slower, taper the steroids more slowly for that patient. And this is a question that's commonly asked, and there is very little evidence. I have put a link or a reference at the bottom to a systematic review looking at kind of SRS and timings of systemic treatment and when to stop it. So practice varies, and actually it should be very individualized. So looking at the volume of the brain metastasis, the larger the volume, the more likely there is radionecrosis. And so we would be keen to avoid anything that may increase that risk. The extracranial disease burden, do they need their systemic treatment a lot quicker? And obviously the agents and the half-life. So this is what we do here. You'll see HER2 agents can continue uninterrupted with SRS. Immunotherapy, again, generally continue uninterrupted. However, usually if patients have been started on steroids, it's interrupted anyway. And you do have to be mindful that you can get a pseudo progression with immunotherapy and SRS, where actually afterwards it looks bigger, but in time it will go down, as you can see outside of the body as well. The TKIs, BRAF inhibitors, Generally, we stop on the days of treatment and up to 3 days either side. And again, that's where we have that individualized approach and discussions amongst the, with the primary team as to the kind of risks and benefits. And then chemotherapy in general, we stop kind of 5 to 7 days either side and during the treatment. Very briefly, radiation necrosis is very common. This is, it can occur around 3 months after treatment up to a couple of years after treatment. It may be exacerbated. You may see a more florid response if a patient is receiving immunotherapy. Generally, the majority of patients are asymptomatic, and it's just something that we see on those routine scans, and management is observation with a short interval scan to see how it's evolving, and the majority of them settle down on their own. So it's really important to know how the patient is and if they're symptomatic. If they are symptomatic, then steroids are the first kind of stay of treatment. However, if it's still concerning, then we may consider operating. And it can sometimes be very difficult to distinguish between radionecrosis and tumour progression, and sometimes only time will tell with that. So we can give repeat SRS. So as I mentioned, it's common for other brain metastases to crop up elsewhere in the brain. We can treat new lesions, providing 3 months has elapsed since their last SRS treatment and all other previous SRS criteria are met. If the same lesion requires retreatment, then again, we can treat. Here, we generally would only give a second retreatment, and it would depend on where in the brain it is. The commissioning guidelines state that 6 months must have elapsed. However, for a retreatment of the same lesion, we would be wanting a longer time interval because the risk of radionecrosis is much, or symptomatic radionecrosis is much higher in patients who have a retreated area. Very briefly, after surgery, we used to give whole brain radiotherapy to all patients. However, we don't tend to do that anymore. And we've had 3 trials looking at whole brain radiotherapy, or SRS. And just to summarize them, both whole brain radiotherapy and cavity SRS following surgery reduced the risk of local recurrence in that area. So as you can see, quite significantly, from around 60 to 70% down to about 20 to 30% at 12 months. However, this did not result in an improved overall survival. Whole brain radiotherapy, as we saw before, results in reduced relapse elsewhere in the brain. However, patients who received SRS had better quality of life, longer functional independence, and longer time until cognitive deterioration. And so generally, we think either active surveillance with regular MR imaging for patients following surgery, or cavity SRS. And in the UK, we're limited by the commissioning criteria that only allow us to give cavity SRS for patients who have had an incomplete resection. So those who have had a complete resection generally tend to go on to active surveillance with regular MRs. So very briefly, brain metastases and systemic therapy. So this is an increasingly complex area of brain metastases, neuro-oncology, and we're in desperate need of more trials to help guide us in this area. I've tried to summarize a few general principles to try and simplify it and help when you're seeing patients in clinic. These principles are assuming that the patient is of good performance status and has controlled or controllable extracranial disease and would otherwise be able to receive SRS or surgery. Okay, so this isn't for those poor performance status patients who, as we talked about before, would be for best supportive care. So if you've got someone who is very symptomatic or has a higher burden of intracranial disease, then treating first with brain-directed therapy is important. Either surgery, depending on where it is, or SRS. For example, if you've got a metastase in the brainstem, I would be very worried about leaving that and seeing whether it responds to systemic treatment, because the larger it gets, the harder it is to treat, and patients could become symptomatic and unwell very quickly. And then moving on, patients who have oligometastatic brain metastases. So these are patients who have perhaps a small primary tumour and a solitary brain metastase, or patients who have previously had radical treatment for their cancer and are presented just with brain-only disease, no disease extracranially. There's some evidence to suggest, or increasing evidence to suggest, that they should be treated more aggressively. And I would advocate targeting kind of brain-directed therapy in addition to systemic therapy for these patients. For patients who have asymptomatic low volume metastases, so perhaps those that have been picked up on screening scans with small metastases that they wouldn't have otherwise known were there. If they have a systemic treatment option available that has a high CNS penetrance, they may be best served with systemic treatment in the first instance, particularly if they're young and they're in that best prognostic group. They've got, 4-year survival. Trying to avoid the risk of side effects from giving radiotherapy is also important. And we have very limited kind of data for this, but on my next slide, I've summarized some of the treatments that are recommended in the kind of ASCO guidelines, really, for brain metastases management as to who might benefit from this approach. And then again, patients who have very disseminated extracranial disease and perhaps limited intracranial disease are probably going to deteriorate and die from their extracranial disease before the brain metastases cause a problem. And so these patients may be better served, again, by systemic therapy first, particularly if it does have good brain penetrance. And obviously it's all on a very individual basis, but it may be that systemic treatment is the most appropriate approach for those. And then just finally, when you're thinking about intracranial progression with stable extracranial disease, so the brain is sometimes described as a sanctuary site. So basically where systemic treatments don't cross that blood-brain barrier. And so you can see that patients respond really nicely extracranially, but intracranially, the brain mets are progressing. And so for these patients, if they're amenable to SRS, or surgery, then I'd consider brain-directed therapy, and that might allow them to have longer time on their systemic treatment, so you're not getting through those systemic lines too quickly. Just a caveat to that really are patients who perhaps have numerous brain metastases that are cropping up very quickly, because if you're giving SRS, as I've said before, it doesn't treat the rest of the brain, and so perhaps a switch in systemic treatment might be sensible for those. These are obviously a rule of thumb. Not everyone fits into these categories, or these categories are appropriate for everyone depending on disease site, but it's just a way of kind of thinking about it really. And for any patient who is commencing on systemic treatment in the first instance, who would otherwise be eligible for SRS, I'd advocate an early MR scan, perhaps at 8 weeks, to ensure that there is an intracranial response. And just as I mentioned before, for those patients with the asymptomatic low volume disease, the guidelines recognise that we've got very low quality evidence for these patients. However, patients with targetable mutations in non-small cell lung cancer, if they've got asymptomatic kind of screen detected brain metastases, then it's reasonable to try with a targeted agent first to see if they respond. Particularly those with ALK mutations do very well with systemic treatment. The EGFR mutations, it's important to say these are the kind of 3rd generation TKIs, so alatinib, gefitinib don't have the same intracranial response as osimertinib does, and so most of our patients are starting on osimertinib anyway, but it's just important to recognise that it's the newer generation TKIs. Immunotherapy, there's very little kind of evidence to suggest that just giving immunotherapy alone, apart from perhaps in melanoma with combined ipi-nivo. But in non-small cell, they do recommend for those with PD-L1 positivity, if they're immunotherapy naive and they're having a combination of chemoimmunotherapy and they've got small asymptomatic brain metastases, it's reasonable to try that. And you've just had a talk on HER2 breast cancer, so I won't go into that. Just show some of the intracranial activity of some of the targeted agents. There was a retrospective study that had been done looking at EGFR patients having SRS versus TKI, and it showed actually a worse outcome. But this was actually done before osimertinib. This was with the earlier generation TKIs. So as I said, the osimertinib has been shown to have a good intracranial response. So take-home messages. So brain metastases are common. For patients with good performance status with controllable extracranial disease, aggressive management should be considered, and consider referral to neuro-oncology MDT if patients fit in these categories and would be eligible for treatment. For poor performance status patients with no further systemic treatment options, best supportive care alone may be the most appropriate action. And volume is important for patients with brain metastases rather than number. Surgery may be considered if there's a larger brain metastase or mass effect or risk of hydrocephalus. And as we talked about, systemic treatments are becoming increasingly important for these patients, but we need further evidence for brain metastases. And thankfully, as Vinton said in his talk earlier, we are seeing more trials being conducted. So hopefully we'll have better quality evidence to guide our management. I've just summarised here a few kind of good resources, really. There was a brain metastases special issue in Neuro-Oncology Advances published in 2021, and it's got separate articles on brain metastases in lung cancer, melanoma and breast cancer. Just summarises some of the evidence and is a good read. Obviously it's a couple of years old, but the general principles are there. Obviously the brain metastases guidelines, and there was a publication just at the end of last year that looked at a kind of management algorithm, a kind of practical approach to what to do with patients with different numbers of brain metastases, which is also useful. So I'm sure you're sick of me talking now, so thank you very much for listening, and yeah, please do ask any questions. So I can see a few questions on here. We stopped chemo before SRS, however, any role of radiosensitizers like cisplatin or capecitabine? So no, there's no clear evidence for them, and we would be very worried, particularly with capecitabine with SRS, for the risk of radionecrosis. So it's not something that we kind of recommend, really. And then I've got here, do you foresee increasing use of whole brain radiotherapy? Have seen some really good results. Any issues what to do when the brain mets relapse? So possibly, as I said, there are trials looking at those patients with high volume or high numbers of metastases, particularly using hippocampal avoidant whole brain radiotherapy. I think there is a role for whole brain radiotherapy in a very select few patients, as I said before, who are perhaps good performance status, have systemic treatment options, but aren't eligible for whatever reason for SRS or surgery, and their systemic options don't have good CNS penetrance. I think they should be considered, but they need very careful counselling, really, as to, you know, the risks from the neurocognitive point of view. And yes, some patients do have good results, but I think the key is selection, really.
Hi, sorry, I think I dropped off for a second there, but no, sorry, I dropped off the call, not that I fell asleep. Thanks for that, it's really helpful, and particularly knowing what you need information-wise for the MDT. I'm sure I'm guilty, I'm sure, of sending some referrals that probably don't have the requisite information. But in terms of, you said obviously they need to have a cancer diagnosis. Does it need to have a tissue diagnosis, or can you treat people on radiological diagnosis?
So ideally, yes, a tissue diagnosis before we treat, because obviously once we treat with radiotherapy, they're you know, they don't have, you're not going to get that tissue diagnosis, and we want to make sure we're not treating the wrong thing. Very occasionally, if it's very clear what the diagnosis is, you know, if they've got a large lung mass, for example, and they've got a brain metastase that needs, you know, treatment quickly, then occasionally we have given SRS, but on the whole, we do try and advocate for them to have a histological diagnosis, yes. And we do need, part of the SRS commissioning criteria is that they have an established diagnosis. So that's why sometimes patients come through the neuro-oncology MDT really early in their pathway if they've presented as a synchronous presentation. And it's very frustrating from our end because we think, well, you know what, actually we need to treat their brain, but we're waiting for that kind of diagnostic process to go through. And so that's why it's really important to, you know, when these patients do present, it's particularly important, I guess, for the peripheral hospitals where they tend to present, that you don't just sit and wait for the neuro-oncology MDT outcome. You have the kind of disease site specific teams or the cancer of unknown primary team actively investigating where the cancer is and trying to get tissue so that we don't have long delays, because what you don't want is the brain met progressing and then us not being able to treat it.
Sure, no, absolutely. Obviously, you mentioned in both your talks about how the incidence is partly going up because we screen more. What would be your opinion on any patient with metastatic disease? Do you think they should be having CNS imaging, or do you think that would just increase the number of treatments we give without improving their outcomes? And Vincent, you can give your opinion as well on that.
Yeah, so I think from my point of view, I don't think every patient, because there are some disease sites where it is uncommon, and so you would be, you know, where our radiology sources are already massively stretched, and so you'd be putting an increased burden on for only picking up a few patients. I think, but it's difficult in those, like, for example, lung cancer patients. I mean, we do a lot of screening anyway, and I think that's appropriate because these patients, they do have such a high propensity to spread to the brain. But you also have to think about the impact on the patient. As I said, their loss of independence from driving. So no, I don't think every patient should be screened, but where there is a role, I think perhaps needs more investigation.
Yeah, I would definitely say that more studies are needed in this area, and there are questions for kind of select groups. It's all about identifying that high risk population where they're going to benefit from the screening. And there's always going to be the question, well, if you pick it up sooner, does that necessarily change their outcomes? So I think at the moment that there are a lot of questions in the community, but I am seeing it more and more, kind of particularly in the lung cancer and the melanoma community, where actually there is a feeling that early treatment, particularly with the systemic therapy options now available, that could really improve outcomes. So I think the community itself really does want that answer. It's just who is going to design that trial. There was one other question, actually. I don't know whether you picked that up, Richard, Aaron.
Yeah, sorry, I think that came through as my connection went off. So a question on I assume for new diagnosis, what dose of steroid we should be using, and about whether we should give VT prophylaxis to these patients if they're inpatients.
So steroid treatment is always a difficult one, but I think for patients who have tiny asymptomatic brain metastases with no edema around them, they don't necessarily need to start on steroids. For patients who present symptomatically in extremis, then you would start high dose steroids and then taper them down fairly quickly, so 16 milligrams straight off, for those patients who are very kind of moribund, really. For those patients in between, who have perhaps a larger metastasis with some significant edema on the scan but mild symptoms, you would perhaps start a lower steroid dose, perhaps 6 or 8 milligrams initially, and then reduce down. But it's really important, if a patient does present with a brain metastasis with lots of edema around it and are symptomatic, that you don't taper their steroids down and stop if they've not received treatment, because the edema will come back. And what we can sometimes see are patients are started on steroids, given a week's worth and discharged from hospital, and then they bounce straight back in a worse state because the edema's come back. So it's really important that they know what to do and what to look out for. And I think VTE prophylaxis, so patients with cancer, and particularly patients with brain metastases or brain cancer are at high risk of DVT or PE. And the mortality rate, for example, from having a PE is around 30% if it's untreated. And so there's always been this concern as to whether to give VT prophylaxis. And I think if there's no acute intracranial bleed, they're not having immediate neurosurgical intervention and they are less mobile, then yes, I think VT prophylaxis is appropriate, but obviously they do need to be counselled that there may be a risk of bleed within the brain, and it's that kind of risk-benefit discussion.
Brilliant. That was really great talks from the both of you. I think there's no more questions from the audience, and we've reached 7:30. I don't know how that happened. It went really quickly. So I'd like to thank the both speakers for really excellent talks. I can see from the feedback from the chat that lots of people appreciated those talks. So if there's no further questions, I'll say thank you to both the speakers, and we'll call that tonight.